Welcome to Community Conversations hosted by Gilda, Gilda's Club Twin Cities. So I'm Shaniqua James. I'm a social worker in the Twin Cities area, but also a group facilitator at Gilda's, which I enjoy very much. And we have a panel lined up for you guys tonight on a very relevant topic that is near and dear to all of our hearts. So let's start by having the panel sort of introduce themselves. Just give a brief summary of who you are, what brought you here, and then we'll get started with the panel. Susan, you want to start us off?
Sure. My name is Susan Smith, and I'm a member of Gilda's Club. I was initially introduced through my late husband, Bill Smith. He passed in 2018 for metastatic lung cancer, and we both went to Gilda's. And I'm here because I have a heartfelt interest in the topic and making a change.
Thank you, Susan. Awesome. How about you, Rhianna?
Hi, I'm Rhianna Berry of the African American Breast Cancer Alliance. We started in 1990, so we will be celebrating our 30th year in October this year. And I'm also now a two-time breast cancer survivor, and we head up a support group and education group for African American women with breast cancer. However, our group is open to other women with other types of cancers too.
Wonderful organization. Love it.
Thank you.
Linda, you want to introduce yourself?
Hello, everyone. My name's Linda Karandi. I was introduced to Gilda through Carly, and that's how I also met Rupa. She would speak so highly of the organization and how much it helped her with her journey. And Rupa invited me to join. I'm a medical student right now, a third-year medical student, very interested in health disparities, especially as it pertains to Black women and childbirth, but also in other facets, as well as immigration health. And I'm happy to be here.
Yay! Awesome. Thank you, guys. So if you haven't already heard, we are going to be talking a little bit about health disparities, specifically to cancer and the African American or Black community. So with that being said, I'm curious to know from the panel, how would you guys sort of like define health, wellness, and health disparities? Let's just sort of start there.
Well, I'll start. Basically, we found when we started that a lot of women had health disparities through social issues, financial issues, educational issues. Even the myths around cancer kept them from actually seeking treatment or even understanding what cancer was. So with those types of disparities for them, it kept them from getting treatment or even understanding the treatment they were getting. And so what we know is that Black women and Black people have the highest level of mortality in this disease, and unfortunately, that could be reduced. And we have to actually help reduce that with education and action, because learning that we have cancer and not doing anything about it, and then doing something about it, and then being turned away or being reduced in their level of care causes another issue about death rates for them.
Mm-hmm. Mm-hmm. So what I'm hearing is really like the mortality rate and like the level of care is a health disparity within the Black community as it pertains to cancer. Is that what I'm understanding?
Absolutely.
Yeah, I'd like to, were you finished, Rhianna?
Yes.
Okay, so I would like to say that even if, my husband and I had great insurance. He was a second-time cancer. He had been stricken with cancer twice, so he was unlike many men, he went to the doctor regularly and encouraged me to do so too. So, but I still wonder, is there something that we weren't told about, or did we miss anything? Could his outcome have been any different if we had maybe doctors that were more aware of African American health or the outcome? Or so I often wonder that. if it could have been different. I don't want to dwell on that because there's not much I can do other than what I'm doing now, speak to that. But just, I have an interest as a surviving spouse, but also wanting to educate my family members as well, if any of them have ever received that diagnosis. But just in general, knowing that kind of gives you a sick feeling in your stomach, knowing that maybe there was something that could have been done but wasn't done because its outcome was so different.
I'm glad you brought that up, Susan. I think that's a really unfortunate sort of a fact that people of color, specifically African Americans, have to deal with, especially like in the cancer realm. It's like, ooh, we always have to question the quality of care that we're getting. Like, are we getting the treatment that we deserve? Which is a huge burden on top of having cancer, right? Like, we already have this stress, and this is just an added layer of stress. And it just sort of worsens the health disparity that we.
It does. And to be honest, I think we got the care, but there's always that. It's just like when I left my job and they said, you know, you haven't been paid the same. I'm like, okay, how long has that been happening? Big old question mark. So, yeah, and you're right. You shouldn't have to worry about that.
Right. Yeah.
I just wanted to add, thank you so much, guys, for sharing. So it's interesting as a Black person, Black student, because we get it from different, like personal experience versus getting professors, you know, talking at us. And one thing that we've been trying to push at our school, they'll always say, oh, you know, Black men are at higher risk for prostate cancer. There's this certain type of breast cancer that Black women are more at risk for, but we're pushing for the why, you know. Is it genetic? Is it something that's actually biological? And it's rarely the case. It's usually socioeconomic, getting prostate cancer screening, and then just disparities in terms of, like you said, equitable healthcare. And I think that's like my interest because, you know, racism and bias don't stop when you enter a hospital door, right? Like, as much as you want to treat every patient the same, you don't. And if you don't acknowledge that, you do give different levels of care. And I think that can be very frustrating because we're often, you know, told we're overreacting or, you know, it's just like, well, this is the standard of care. But we bring our biases with us everywhere we go. And how does that affect the people who are our patients, right? And hearing you talk, Ms. Susan, about your husband, or Ms. Rhianna about your foundation, it's interesting because we're often, you know, as medical students and future providers, given very surface level, like we'll just kind of get a slide that says, oh, these are the cancers that, you know, Black people are at higher risk for, but we never delve into the why or what we're doing about it. So conversations like this inspire me because it's, you know, when school gets hard, like there's a reason we need more Black physicians. And, you know, whether it's in the field of oncology, whether it's in the field of OBGYN or just primary care, which is usually where people start with the whole treatment. I think it's really important that, you know, health disparities are not just about seeing who is more at risk for something, but the reasons why. And I think that's something that's definitely missing in medical education.
Yeah.
True.
That's interesting that you said that, Linda. You weren't a part of the part one conversation that we had as far as like community conversations about health equity. But it's interesting because we did talk a lot about providers of color and like how there is just a lack of it in oncology. Like even for this session today, like our search for someone in oncology was obvious. It just turned up nothing. Like it was just so difficult. And I don't know if medical providers really understand like how important it is for someone to be able to connect with you and like see themselves in you when you're getting care. And that sort of goes into the quality of care that people get and like the level of care like Rhianna talked about. So just interesting that you said that, but I do agree we do have to address some of like these underlying reasons that Black people are at higher mortality rates for some of these cancers and get like the more aggressive cancers at higher rates than peers. So I'm curious to know, when we talk about that, how Black people, African Americans are at a higher like mortality rate and to get cancers, and we talk about, you know, psychosocial sort of things that relate to that. What is it that we can really do to address some of the things that we already know about Black people getting these cancers? Is there any information out there? Is that something that we just need to research a little bit more? Or like how is it that we can really address that piece of it?
Well, for me, preventative. There's some preventative measures I think that we can take in terms of diet, exercise, the things that, you know, my primary care has told me for years that, you know, I just like, okay. But, you know, as you get older, it suddenly gets real, you know. Like, okay, I got it. I think preventative, and I wanted to speak to something that Linda said. I think the biggest thing is that unconscious bias.
Mm-hmm.
And until people address that, they will continue to think and give out of their own experience. And that's what's so dangerous, I think, is that some of them may be aware and some may not. But that has to be addressed. But I think preventative. And another thing that I thought about a lot was someone had told me, and I'm not a doctor, so I don't know, but I believe that we're holistic creatures, you know, body, mind, spirit.
Absolutely.
And I cannot help but think about using my husband as an example, and even my dad, and all these good Black men that died too soon.
Mm.
But then I look back over the record of our lives in this country, and I realize that I'm on another panel too, talking about disparity. What my husband went through, the fact that he went to Vietnam but couldn't vote.
Mm.
And the fact that he had to fight to get into Honeywell. So I think about the impact of stress.
Mm-hmm.
Mm-hmm.
And having a place to go where women and men of color can vent and get some of that out,
Mm-hmm.
rather than internalizing it.
Mm-hmm.
Because I look at my dad with hypertension and just all of that, and I'm just like, there's got to be something that we need to begin to treat ourselves holistically.
Mm-hmm.
So that's what I was thinking. There's some preventative measures, maybe.
Yeah. It sounds like overall wellness.
Overall wellness.
Yeah, I like that.
Top of the head to the sole of the feet. Yeah.
Yeah.
Yeah. I just wanted to comment on that. I think that's so powerful, and there's actually like medical evidence about how our body remembers trauma. And it's hard to kind of like, you know, quantify, but there are things that people go through that generally will affect their health. And they did studies on like little kids who were born in like households where they either saw a lot of violence or they experienced a lot of, and when they got older, their health was just generally worse. So I think there's a huge testament to like the experiences that Black people have gone through in this country. And, you know, when we talk about hypertension, like Black people became the face of high blood pressure, right? But if you look at Black people in Africa, they said, why are they, if it's genetic or something that's in our melanin or our skin tone, why don't they have it? It's really about the lived experience. So it's not race, it's racism, right? It's, those are the things that are contributing. And I'm like, you know, I'm not an expert at all, and I am not a scientist in the like research field, but I'm sure it has the same things in cancer. Like there's things, like you said, we're multidimensional beings. We don't just exist as equations and formulas. So why someone might get cancer and someone does the exact same thing and doesn't get cancer has a lot to do with that, like the stress and the opportunities to just feel like you have a space to be heard. And I feel like Black people miss that a lot. And at work, you know, we have to act a certain way or kind of conform a certain way. And then, you know, whether it's at school, and then finally just having a place where you can just be and someone gets it and they're not asking if you're overreacting or taking things too far. It's important for us. Like, I really think so. Yeah.
Or, I think, you know, or if you assert yourself, it's just like, oh my God, she's like, no, I'm asserting myself. That's all.
Yeah.
Yeah, I can't even count how many times that I've been called aggressive when my voice raises. Well, I'm gonna be myself, so here I am.
Yeah, this is it.
Yeah,
Yeah.
that's what it is. Yeah.
Yeah, that's so true because on 2 points, there's bias on both sides of the patient and the medical professional. We have this attitude as Black people who have been oppressed for so long and dealing with oppressive issues as we know today, that it does affect how we understand our diagnosis, how we understand our health, how we tend to want to find ways to make our lives better, our health better. There's a quote, they said, well, Black people don't exercise a lot. And it's because they said historically, Black people working in the fields all day, 12, 15, 20 hours a day, for them to come home to get rest was the main thing. So now they think that I worked all day. What did I need to exercise, do an exercise program? So it's that kind of built-in history that Black people are dealing with. And it also affects how they teach their children about health and what's good and healthy. So we tend to pass along our habits sometimes. And this is something, like we said, there might be some bias in the medical field about how Black people take care of themselves. You know, so if they say, well, we don't want to give Black people a lot of medication because they'll become drug addicts. And then they decide that if a Black person and a white person has the same level of pain, well, the white person has more pain, so they need medicine, but Black people with the same level of pain don't need as much pain medicine. So we know these kind of things are happening to us in this society. We know that it affects how we deal with the medical professionals, and it does come down to trust.
Absolutely. There is such a distrust. And I didn't mention it in the introduction, but you know, my personal connection to cancer was my mother had breast cancer before she passed in 2018. And I could see a lot of the sort of trauma that she had with dealing with medical professionals sort of passed down to me. And there was such a distrust there that it was a part of me when she was first diagnosed that was not confident at all that she would make it. And like her passing, sort of affirmed that for me in some ways. And I know that that is definitely a part of like the bias that I have for the medical field in general, when it comes to them treating Black people. So Rhianna, I agree with that notion completely. And I'm glad you said that, honestly, because it just made me sort of think about that a little differently, in a different perspective. So how do we even begin to address some of these things? I know in my experience, one thing, I've never had a physician or a medical professional sort of like name some of these disparities that they've seen, and, you know, just sort of like name the awkwardness that comes with having a provider that doesn't look like you, that, you know, that may not understand like some of the stressors you have, or like understand the importance of having someone who looks like you caring for them, and just the differences, like just sort of naming it and putting it out there, not letting that air be a little stiff. But what do you guys think? Like, what are some ways and things that we can do to sort of like address some of these things that we're talking about?
Well, as a patient, I'll say the doctors get 15 minutes with a patient, pretty much. And there's no way that they can get a patient's background, feelings, concerns wrapped up in 15 minutes. And of course, that kind of puts the patient off. It's kind of like I'm rushed in and rushed out and I'm not heard. So they walk out of there thinking, did I get the care I should be getting? Does my doctor really care about what's happening to me? Because I know a woman now, you know, she feels as if now that her breast cancer has metastasized, she feels as if the doctor didn't do enough. So this is a concern. How do we address that, and how do we educate patients to be able to talk with their doctors straight up?
That is so true. One of the things that I use with my with Bill's doctors, I was glad that they had we had an oncology nurse. So what I would do if we had questions in the middle of the night, I'd write them down. And then before I visit, I want to address this, 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 and this. So that when he came in, he knew what I wanted to talk about. It gave him some time to prepare.
Right.
That's one thing. But I also like the fact that Talea, the doula concept.
Yes.
Mhm.
I think there's got to be a buddy system or a group of people that people can tap into to go with them. A lot of it is prep because you're right. Under the constraints of health insurers, they want you to do 15 minutes, 20 at the max, in and out. That's not enough time. And I also think that they have to have some support groups too with people that look like us.
Mhm.
So that people feel comfortable bringing it. Because in our community, I feel there's still a lot of secrecy. In fact, when I talk about Bill's cancer, I can just feel the people just kind of like, don't go there, don't go there.
Right.
You're going to be all right? Yeah, I'm going to be all right. I can talk about it. But how are you, how do you deal with it?
Right.
Because he has 5 brothers, 4 of which all had prostate cancer.
Wow.
All grew up in the South. And from what they told me, that was stressful.
Yeah.
It was stressful when they grew up on a lot of different levels. But I think those types of things would help. There's got to be a way that we can, and I try and talk to anyone in my area, circle of influence, to talk about support groups, because I believe that is another facet that can help everybody, deal with or get through a diagnosis. You need to have support. I don't know how people can do it. We even had friends that, especially men, and they didn't want to talk about their prostate cancer. Bill was very open, and he tried to get other men to be as open because they struggle.
Right.
They don't even know about some of the enhancements that have been made that will allow them to, have fulfilling sex lives. So there's got to be a way that we get over. Spirituality is great, but the church can't help you because they're not doctors. I think you need to go there for your faith. I think you need to get real information with people who are going through it. And we need to create support systems like what you're doing at Rhianna is great. I told you, I think last time I had a good friend that went through, and it helped her immensely. Yeah. Those are just a few things I think. Preparedness, a doula, and support groups.
Doula, yeah, I love it.
I love that doula. I'm like,
Yeah.
I could see me doing that. I would love to do that.
Linda, did you have something to add?
I was just going to say, I think social media too has been huge in sharing stories, right? Like you said, people tend to shy away from talking about things. And most recently, Chadwick Boseman, when he passed away from colorectal cancer, I was amazed at how many Black GI physicians started saying, like, Black people need to get screened earlier than the guidelines. So the current guidelines are you start at 50 unless there's a family history or any other indication that you should start earlier. But, these are things I didn't even know. And like, my dad started at 50. He's a physician. Like, there's just things that I think we're still learning. But if one person shares their story, or a spouse shares their story, or it encourages other people to kind of come out of the woodworks. And I think Twitter or Facebook or Instagram has been great for that in terms of support groups, especially now when we're, social distancing a little more and maybe not able to go out as much. It gives people a chance to find community. And if it's like, okay, one person says, yeah, I'm 35 and I didn't think I would get breast cancer, and here I am, here's my story. More people are empowered, more people will get tested, and we kind of take away that stigma. And I think that's really important. I still haven't figured out where it comes from, but it's there and we can't ignore it, right? Like, it's still kind of hush hush. And, what you mentioned about the church is important because my dad, he works at North Point, which is one of the clinics in North Minneapolis. And he has really pushed for the women. So I'm Kenyan. And so there's a lot of interplay with, like, not only fear, but also just a lack of understanding about the Western culture of medicine. So he has really tried to push for just advertising breast cancer screenings. Like, they're free. We do these fairs, like, come and get them, you know? And because a lot of people, the issue is access and finances. And what I found that doctors can do that's really frustrating is also kind of victim shaming or blaming, or if you had only done this, that this wouldn't be the case. And they're already doing that to themselves. So I just feel like it's really unfair. If there's any way that we can mitigate some of those things. And I think it starts with one person saying, hey, you know, I got tested and I found out I have this, or my father went through this, or my husband or my spouse or my partner, whatever the case may be. Because once we start removing some of that and giving people a place to speak up, it's incredible. Because after Chadwick Boseman's story came out, so many people said, I'm Black and I didn't think that this would be the case for me, but here it is, or my dad or my, you know, family member. And it was powerful to see. And it also pushed me to like push other people in my life, like, you need to get screened. This is not, you know, it doesn't skip over us. It doesn't discriminate, which is important too.
Right. Yeah, that goes with the history of the big C. That's how Black people actually spoke about cancer.
Right.
And it's the history of even skin cancer. Oh, we have pigment in our skin, so we'll not get skin cancer. And so consequently, now all of these cases of skin cancer are popping up in the Black population, and people, I can't believe it, you know. And then it shifts over to this word hoax, you know. It's like, are you sure? What did they do? Maybe it's in the food, you know. We're trying to find other reasons why this happens, and we need to all understand that the human body is the human body. And it's made of cells. The cells go bad. They could be a historical cell. It could be passed down through the family. It could be an environmental cell that goes bad. And that's the part of explaining what cancer and diseases are, because someone right off the bat is going to say, oh, somebody put a hex on you, you know. Something silly, you know.
No,
and that
is true, yeah.
Yeah, and it perpetuates through the family and through society. We're still fighting the misconceptions about cancer.
Yeah.
After all these years.
Yeah.
Mm-hmm.
That's a really good point.
Yeah, that is very true about the skin cancer. Because I was in the Bahamas once. I'm like, oh, I got melanin. I burned myself up. I look like fried bacon. I tell you. My mother's like, you told you don't lay out in the sun. So yeah, you know, just ignorance. Oh yeah, we got melanin. We don't need it. I'm like, no, you were born in Detroit. You were not born on the continent, honey. So yeah.
That's funny, and that's true for me. That's true for me too. Like, I just started wearing sunscreen like last year. I'm like, oh, Black people can. Oh, okay, well, all right.
Okay. Tell me no more, because that's right. And it's just those myths. So you know, I'm just believing like us, even with menopause. People, I'm not gonna go through. I'm like, okay, you tell me you're not gonna go, don't go.
That's
all the myths we have, you know, I'll just pray it away. I'm like, you let me know if that worked when it happened.
Yeah. That's a good point. And it sort of leads me into like talking about like myths too. And Linda, you also mentioned Chadwick Boseman, and I know that it came as a shock to me. And there was like a component of it that made me feel like it had to have been lonely, right? Like the public didn't know. I'm sure he had a support system behind him, but that sort of goes to like the myth that Black people have to be strong, like regardless of what they're going through, and like you can't really show when you're having any emotion other than tough, right? Like other than like being that strong person. And that just sort of leads me to, well, how can we sort of push forward like and dispel that myth in itself, so that people are getting what we described here as like holistic, whole person health and like wellness.
So it's interesting that you brought that up. I think, Ms. Rhianna, you talked about it earlier with the myth that Black people don't feel pain the same way. And there was this huge research study that was done that looked at, medical students, residents, doctors and the surveys that actually show that they don't believe that Black people feel pain the way white people do. And then, like I said, I'm really big and active on Twitter. And one woman said that she went to the hospital and the doctor said, "Oh, it's fine that you're going through this because I know you're strong." And it's like, no, this is the place I should come where I don't have to be strong, you know, like I'm in pain or I need help. But that myth, I feel like we also use it as a compliment. And it's kind of catch-22 because yes, I do believe that we are strong, but we need spaces where we don't have to be. And to what extent is it happening at our detriment, you know? And I think, kind of going back to what I was saying, if one person says, you know what, I think this is really hard, or I'm actually not doing okay, I don't want to be strong, like I need support. If one person starts saying that, I feel like it starts that conversation. And I do believe that it has been happening. In the issue, for example, I bring up childbirth a lot, but a lot of Black women started coming forward about their experiences with going to the doctor and not being believed, or not even just in the realm of childbirth, but in general. And a lot of it is, we're just not taken seriously. And I don't think that it's, you know, that we're not articulating ourselves well or anything like that. The issue is there's this misconception that we are strong. And I always say it's kind of like a weird duality where we're seen as like inferior and superior at the same time. It just doesn't make sense to me. Like how those exist.
Yeah.
But yeah, I assume all of us here identifying as Black women, and please correct me if I'm wrong in that assumption, but you know, I think strength has been used as a way, almost as a weapon against us. Like, you guys are strong, you got this. And it's like, no, we need help. We're in this realm, whether it's mental health, physical health, or otherwise. And I think it just takes like one person to just say, hey, no, I'm not strong. And I think a lot of people have actually started doing that. I keep bringing up social media, but multiple people will share their stories, or even, you know, I'm talking about celebrities like Beyonce. She talked about her childbirth experience and how difficult it was for her. Even, you know, hearing people speak about things like that opens the door. But I also believe that we as a community can even do better. It's like, I think it comes from a good place, because I know I say it all the time. I'm like, oh, you are so strong. Like, but we don't always need to be, right? And I especially think as Black women, we're kind of given that burden. And I'm calling it a burden just because with it comes a lot of, unfortunately, just a lot of extra on our back because we're considered to be so strong, you know?
Yeah. Right. Yeah.
The difference being, I always tell my friends, yep, I spiritually strong, but I still hurt. And if you cut me, I bleed.
Right.
Yeah. And I had to advocate for Bill. And I'm grateful again that he was an advocate, but sometimes he just was tired. And he had a problem where he was having, his esophagus was burned because of the radiation. And they were just like, well, I'm like, nope, I heard you all give somebody else something to coat their throats. I want my husband to have that same thing.
Yeah.
You know, and you have to you got to intervene. But had I not been eavesdropping and heard what they were doing elsewhere, they're like, no, he's not going to just, you know, drink something or drink a milkshake. No, he needs something to coat his throat and to medicate his throat so he can't eat and doesn't lose weight.
Right. Right.
Yeah. So yeah, that's a myth that we need to debunk right away. We can be spiritually connected, but we still have human bodies.
Exactly.
Absolutely. Yeah. And I think a piece of that too is sort of differentiating from being strong and being resilient. Like, I think we're all extremely resilient, but that doesn't mean that we have to be strong. And like, I've made a conscious effort to tell people that when they mean it as a compliment, to call me strong. It's like, no, I'm resilient. Like, I know I can get through it. I know that I will get through it, but I'm having some weaknesses right now. Like, I'm still emotion. Like, you know, so just like differentiating, like, I can be resilient, but I don't have to be strong all the time. But I completely agree that it really is a burden for Black women. It really is.
It is.
And Rhianna, I think the last time we had this conversation, you sort of mentioned something that I really liked. I can't remember what you called it. Was it like the strong woman?
Superwoman.
Oh yeah, the strong Black woman syndrome.
Syndrome.
Yeah,
Mm-hmm.
yeah. And yes, we do have that because we have been historically one of the backbones of the family and the community. So it's like when women are finding they're having a breast problem or say a vaginal bleeding problem, it's like, oh, I don't have time to take care of this right now because I have to go to work, take care of the kids and do this, do that. So that strong Black woman syndrome means that she's taking care of everybody else but herself. And even the men will do that. It's kind of like, hey, it's just a pulled muscle, but I have to go to work. I have 2 jobs. So we do have strong Black people syndrome also.
Mm-hmm.
It's the sense that we know we're already lacking the insurance in most cases. If you have a job that doesn't give full insurance, or we have lots of children to feed or any child to feed, it's kind of like the primary concern will be food, shelter, and health. I'll get there when I can.
Right.
And actually feeling as if she's a priority. Now, that's the other thing. Sometimes women do not feel that they're the priority in the family. They are the primary caretaker in the family, but she doesn't put that priority on herself.
Right.
So with that type of lifestyle, because it does become a lifestyle, that's the way we live, we have to make adjustments, and women need to take the time out and say, you know, if I'm not here for them, I can't be there for myself, then it comes back, then I can't be there for them.
Yeah.
So it's a mad circle that Black women as a whole face, and even women as a whole face, you know.
Right.
Absolutely.
One thing I shared with a group of women I mentor is I said, you have to put your oxygen mask on first.
Yeah.
You cannot help anybody else if you don't have your oxygen mask on first. And you have to learn what it means to give self-care and when it's enough.
Right. And the right type.
And and the right type of self-care too. Right.
Yeah.
Right. Right. This right healthy self-care, learning to meditate, yoga, anything, going for a walk even, just to disconnect from all those 50 things that you want to do that probably aren't going to mean much if you're not here to do them.
Right.
Yeah. Yeah. Absolutely. Absolutely.
Yeah.
And it's almost like we have to give ourselves permission to do that, right? Like,
Yes.
for a lot of times there's guilt involved, or, you know, if I don't do it, it won't get done. And, you know, it's selfish of me, but like you said, you have to put the oxygen mask first. And my version of that you can't pour from an empty cup, right? If you're not good, you can't give to anybody else. So, and it's unfortunate. Like, I think that our whole lives we're kind of taught, at least for me, I'm the firstborn girl, like you're kind of taught, it's ingrained in you to pay attention to everybody else. You don't eat until everyone else has food on their plate, you know. And then even then you're kind of making sure and nobody needs seconds. When, like, I used to look at my mom, I was like, when are you gonna eat though? Like, you're worried about everybody else. And it can be hard to unlearn that behavior, I think, especially when it's years and years and years of kind of being taught that. But, you know, it happens at the expense of our health a lot of times.
Exactly.
And therapy can help you unlearn a lot of those behaviors. Like,
yay.
Right. And you know, and you know, we all have those planners. I'm like, put yourself in there.
That's
put yourself on that schedule. The things to do you.
Right.
Whatever that is, put yourself in there at the beginning of the day. And like I tell my daughter, because it gets to be overwhelming, and I get it. I do get it. But you really have to learn to put yourself out there, you know, first.
Absolutely.
Yeah.
Agree completely.
And be a little selfish, because Lord knows we give above and beyond sometimes. We do. So if they miss something, it's like, oh my, take me over, put me on TV.
Right.
What did you miss? You had food, clothing, shelter, and parents that loved you, and a mom that loved herself enough
Right.
to take care of her, so she was there for you.
Right.
Yeah.
Mhm.
Yeah.
And dads too. I mean, we all have to do something. Yeah.
Yeah.
Mhm.
I agree. So I do want to be mindful of the time, but I'm curious to know, what do you guys think that we need to do, or what are some actionable items that people can do just in general to sort of advocate for some of the things that we've talked about here today? And that can look like specifically like with medical schools, teaching more culturally competent care for cancer. It can look like what can we do as patients? What can the medical field in general do to sort of help forward some of the stories that you talked about, Linda, and just getting them across, like resources. It can really be anything, but I'm curious to know, what do you guys think needs to happen, and what are some actionable items that can be done?
I think from a personal position, I like what Linda said, you know, we all have access to social media, and maybe just doing a quick check on our own circle to see where everybody's at. I have a group, a widows group, that we check in every Saturday. They just send something out, where you at, you know? And doing something like that helps people feel connected to a group. I also would like to know what clinics are doing, because they have to have noticed that this is an issue, especially clinics within the community, in communities of color, like North Point, North Memorial. They all have clinics that are on the north side, and I'm sure on the south side throughout the city, and maybe reaching out to see what are they doing, or how are they dealing with the disparity, or do they even recognize that there may be a disparity?
Right.
Where are they in the evolution? You know, because everything's so sensitive now because of what happened with George Floyd, his murder, but you know, it goes beyond that. Because I saw a post that was very poignant, and I posted it. It talked about, yes, it is police brutality, but what about the doctors? What about teachers? What about all those other areas too? So we have to begin to at least have the conversations and maybe connect with people who are in positions. I don't know where that position would lie within a clinic system, but I'm sure there's a community outreach. If they have a community outreach area, finding out what are they doing.
I think it takes more than just handing out pamphlets on a table at a fair.
Right.
Oh, it's a conversation.
Right.
It's definitely it's a conversation, and it's intentional. Has to be intentional.
Right.
When you put stuff out there, well, we're putting it out there. Well, you know, anybody can come along and put something over it. I mean,
Yeah.
that's not that's convenient, but it's not intentional.
Right.
So I want to echo what you said, that I think a lot of people don't want to do uncomfortable work. So it's comfortable to put a pamphlet and kind of clear your conscience. And like what we said, that if they ever had any questions, they can come to us. But the uncomfortable work is taking that extra second to say, I realize I'm a white provider, or I realize, you know, I'm a straight provider. I realize I am this, and I don't fully understand, and I'm willing to, and I would like you to help me with that. And I don't think patients are given the sense that they also have power in the room, like you said, to say, I'm not comfortable with that plan. There's nothing, if you say to a doctor, you're not comfortable with that plan, they should not, you know, it's a conversation, like you said, or can you help me understand, because I was reading, or I'm just curious, and you know, you can, and I think it's frustrating because there's so many competing things, the time thing, and you can tell some of them have their hand on the door and they're trying to leave and they just want you to say yes, but it's your health, right? Like, if the same way you said with your husband, how come he's not getting this? Like, those are things that we as professionals have to be, we signed up for this, to be able to sit there and answer questions. And I think a lot of students across the nation, there's a Black organizations called White Coats for Black Lives, where we are pushing for curriculum change. And I think it's amazing, but that's happening at like different, you know, it's like the future physicians. What are we doing for the current physicians? And I think social media is powerful. So if you have an experience, I would share that with everyone I can. Just like, if you ever feel like your doctor's not listening to you, here are some things to do. And social media has actually started doing that, and I think it's great. And we take an oath to first do no harm. Like, that is, as we enter this field, that is like something we should take seriously. And if a patient ever feels like what we are doing is not in the best interest of their care, it is their right to speak up, and they should not be shamed for that. They should not be, you know, made to feel like they're not smart enough to know. Because my favorite thing is, we may know science, but people know their bodies. There's no way I can understand what's going on inside your body. So it's up to you to tell me. So I think just viewing that relationship more as like, it's very patriarchal. Like, the doctor said this, so I'm gonna do it. And I think more people would actually get better outcomes if they felt involved in their care, and they don't, right? It's like, they said this, or when I go to him, he just tells me what to do. He doesn't listen. He just tells me to lose weight and just doesn't go on into like why I can't lose the weight. Like, there's so many different things. And I think that this generation of physicians, Black physicians, I'm saying, is really working hard, but I still think we have such a long way to go. But I think part of it really does start with uncomfortable conversations that people are not willing to have, because no one wants to feel bad, but we have to, right? In order to make change, people need to hear that, you know what, this profession has been glorified for so long as like a beacon in the community, and it's great. It does a lot of great work, but we still have historical roots in racism that until we have those conversations can't be undone. And I think patients, families of patients who speak up are the ones who are really just my heroes, because they're kind of showing that this is not as great as it seems, and what can we do to move forward. So this is a great start, and it's inspiring me to kind of, you know, push for more to happen at our school too. But even in like hospitals, like you said, like North Point, is there a way that maybe a cancer survivor, spouse of a cancer survivor, can attend like a first meeting, or just be like, here's some questions you should consider asking, because I can't imagine how many different directions someone's mind must be running. Or, you know, here's some things to, like within those support groups, like just saying, when you have your first visit, make sure you mention this, and things like that. I think that could actually be really helpful. But yeah.
Absolutely. Well, that brings me to patient navigation. That's something that should be incorporated into the medical care system and the community care system, because Betty Sanders and I worked for the Women's Cancer Center in Minneapolis 20 years ago. And the one thing we did, we went with the patients to their clinical appointments. They actually needed help to understand what the doctors were saying, what was to be expected, and to know that, hey, you got somebody next to you that's going to help decipher some of this information, and to create a better relationship between the doctor and the patient, because it comes back to trust. For one thing, you have to trust your doctor. You have to create a team. You have to be able to know that you're going through the proper steps for your diagnosis. But for us, it was almost creating a friendship with the patients, because we were kind of like their anchors. It's just like what Talea does as a doula, cancer doula. It's something we've been doing for years. Now, considering that we're in the age of COVID now, how that can be done is going to be a little hard. But it's almost like, first create a list of questions that a patient could be asked. Do you need help with this? Do you need help with that? Would you like someone to contact you about a breast cancer group or a cancer survivor group specifically for Black people? Because that's one reason why a lot of Black people don't go to support groups, because they go to the hospital support group. They might be the one and only Black person in the room.
Right.
And it's like, well, this conversation isn't kind of relating to me, so they leave. So this is something that if we can create a more community-based patient navigation system through the hospitals, the clinics, the social services, because you get referrals. Somebody might not ask for help, but say a social service agency knows this person has cancer. They could say, hey, we have a referral here. We have a network of people, a network of organizations. And that's how we started out 20 years ago. And it's kind of like it goes through changes. They use it for a couple months, then it dies out, you know. So it's constantly, it's never circulated constantly. It's always whoever is saying, yeah, this is a good idea. And then when that person leaves, it's like, oh, we don't know what to do.
We don't know what to do with that. Yeah. Because it has to be sustainable.
Right. Right. Yeah. And because that creates another level of trust, because if you can say, hey, if you go to so-and-so for drug therapy, or you go there for mental illness therapy, we have those connections there. But when it comes to cancer, we don't have that.
Absolutely agree. Absolutely agree. I think about on another level too, on like the meso and macro levels, is don't be afraid to like reach out to like your legislators, like your state appointed officials, and like outline some of these issues, because it really is their job to like address some of these things and like put it into like these laws, so that, you know, we're not having to deal with institutional racism when it comes to like health, especially like in cancer care, and even reaching out to people at hospitals to just sort of outline some of the grievances that you've had with your care there too. So don't be afraid to use those resources either.
Right.
So who in terms of, I love to write letters. So who at the legislature, who would be a recipient of, who would be the best recipient for what I would like to write?
Yeah, so you can just go to like the Minnesota State Legislature website and sort of look up who your representative is, and it would just be the Senate or the House representative. But it should ask for like your address and zip code and things, and it'll pop up and give you all their information. And you can call, you can write letters. I bug mine all the time. I don't care if you don't like me, but it's like if I have an issue, like this is something that you are supposed to address, and like use it.
Right.
Yeah.
Yeah, and there is the Minnesota Cancer Alliance has committees and work groups that really deal with the legislative part of it, the lawmaking part of it. So that's another place to go. Also, the patient rights information that patients are giving, they don't really read it a lot of times. You know,
that thing they should send that out well in advance.
Right.
Like, okay, I'm getting ready to go to my appointment now.
Yeah, so educating people, educating patients is primary also, because with more knowledge, you get more action.
Right.
And then, you know, that's information that should be contained and sent to everyone beforehand.
Oh yeah.
You know what I mean? That's like with your insurance information.
Right.
What your patient rights should be. That should be a part of that, whatever that packet is. Yeah. Yeah. Because giving it to you at the time of an appointment, some people might read it, but yeah.
Yeah, we didn't. Yeah. All right, so we are at time, but I want to thank all of you guys for the conversation. It was informative as usual, and I look forward to seeing y'all again at the panel, and hopefully we get a bunch of questions, and we probably got a lot more to say, so we'll say it. Linda, I can't wait till you are out in the medical field, girl. We need you.
Yes.
I'll keep me in prayer. It's hard.
Great.
Congratulations, though. That's
incredible.
Wow.
Yeah. Susan, Rhianna, good to see your faces.
Good to see you all as well. Yeah. I don't know. Next time we get together, I may be in Georgia.
Great.
While we up here freezing, you're gonna be in Georgia.
We'll talk about you.
You can talk about me. So this was very good. I'm glad that we were able to get together.
Yeah.
Nice
All right,
to meet you, Linda.
Okay.
It was very
Yeah.
nice.